Good evening, everyone. Thank you so much for joining us. Welcome to the Fellowship Center for Racial Reconciliation. This is our COVID-19 and Justice series. This is part two of a four-part webinar series. Part two talks about COVID-19 and the Black and Brown health disparities. This four-part webinar series is really us asking or answering the question, what has COVID-19 exposed in our country? We all know that after the enactment of the shelter in place all around the country, what we decided to do as the Center for Racial Reconciliation, we started to ask ourselves and to pray, what's the best way for us to show up for our congregation and our community? So we came up with the idea of having a series of evenings that focused on how different communities have been impacted by the pandemic. The goal of this evening is to help our congregants and community become aware of the devastating impact of the coronavirus on our brothers and sisters from our congregation and in the larger community. So tonight we're going to have a great conversation with 7 amazing panelists who will examine COVID-19 through 4 different lenses. The first lens is medical, the second lens is historical, the third lens is biblical, and finally, the fourth lens is from a social perspective. Our panelist this evening is our Dr. Nick Nefertiti, and I'm sure I may have messed up his name, but I'm sure he'll give us a lot of grace. We will also have Dr. Don Ward with us, and then another panelist is Pastor and Professor Alexia Salvatierra. We'll have Pastor Joseph Manzo. We also have with us tonight Pastor Rich Viotis and Pastor Ricky Jenkins, and obviously last but not least, our own Pastor Albert Tate. As I said, tonight we're going to look at how COVID-19 is impacting us through issues of race and racism in the area of public health and healthcare industry. We know that as of now, there are over 1 million Americans that have COVID-19. And what we also know is that the data is clear. African Americans and brown communities are being disproportionately impacted by this crisis. Through the infection rates, the hospitalization, even the number of deaths have revealed a distinct gap across lines of race and class. So needless to say, the problem is dire. And I think it begs the question, why does this keep happening? So finally, we want to be able to have this conversation open for everyone. We want this to be interactive. If you have any questions for our panelists, please feel free to write them in the chat, and we will curate the questions for the evening and try to get to as many as possible. We also want you to be involved in this conversation, and periodically we'll be asking you poll questions that we will want you to answer. In fact, before we get started and before I turn it over to Albert, I want to ask the first series of poll questions for us. So I have 3 quick questions for you. How did you hear about this webinar? Do you attend fellowship? And did you attend the first webinar in our series, the COVID-19 and the Asian American experience? So if you could answer these questions for us, we want to take that survey and see who we have in the house tonight. So please answer those questions. And after that, I will turn it over to our dear Pastor, Albert Tate.
I like how these are real-time responses. This is pretty cool, John. This is great.
Yeah.
It's like we're on the show. Oh, there they go.
There we go. So the results are in. Facebook post, 19%, Instagram, 28%. Good news today, 16% from a friend, 39%. I'm really glad to see that. And then other 13%. And then we have about 64% from who are joining us tonight from fellowship, and 36% from other places. Welcome, everyone. And then you heard, and we have 48% who saw us last week or 2 weeks ago. And this is amazing, 52% new people. So welcome. And also in the chat, if you could tell us where you are from, you can just tell us which city, we would appreciate that. And so I'm going to turn it over right now to Pastor Albert Tate.
Well, I'm so excited. Number one, thanks to John and your amazing team. Our church is so proud of the work that we get to do through the Center of Racial Reconciliation. And I know we've got a lot of fish to fry and not a lot of time to fry it all. We got a lot of great experts on the panel. So I'm just going to jump in. Would you welcome to our webinar the Chief Medical Officer for San Diego County, my brother, Dr. Nick. Dr. Nick, so good to have you on.
Thank you, Pastor. Thank you so much for the opportunity.
Dr. Nick, I can only imagine how busy you've been on the front lines there in San Diego County. We've been praying for you. Dr. Nick, not only are you an amazing doctor with a rich history with serving our people and serving in public health, so many serving quite a bit the marginalized and the poor, but you're a man of you're a believer of God and a man of great faith. I've seen that lived out in real time as I've gotten the privilege of spending time with you, and you're a great father. So I'm so thankful for you. I'm going to jump in though. John didn't give me a lot of time, so I got to get this in quick, and I'm just going to ask you just a question everything's been so confusing. Everything has become really political, and it's almost getting more intensifyingly political by the day. There's a constituency of people, I'm seeing the memes, I'm starting to see the rhetoric that feel like that this isn't a pandemic, they call it a plandemic. There are even those that are saying, yo, this thing is not even real. If you look at how many people die in the world a day, this is not even a smidgen. So they're throwing these percentages that make you feel like there's not a panic at all. I saw somebody on Instagram say, I went to the emergency room the other day, wasn't even anybody in there. They only had one doctor on call and that kind of deal. Dr. Nick, my first question is simply this. Is this real? Is this a hoax, or has the media just played us all and got us scared for no reason? Is this really real?
This is really real, brother, and a couple things I have to say quickly at the beginning so people know where I'm coming from. I am a believer first who happens to be the Chief Medical Officer of the county. I am somebody who is thankful to say that I've never seen anybody with private insurance in my life. My whole life has been spent serving those who need it the most. And let me also say that my father was the third person in 2009 to die from complications in the last pandemic that we had of swine flu, the third person in the world to die from complications of swine flu. Wow. My dear mother has not left our house. I am a single father with full custody of 2 little girls. My mother has not left my house since March 9th. And so the fact that here in California, by God's grace, we made some decisions very, very early, and as a result, prevented the consequences that could have easily occurred, I can honestly say there is no conspiracy, but by God's grace, we took cover promptly. I can also testify, Pastor Tate, that as prepared as San Diego is, we live right next door to Tijuana, as you well know. In Tijuana, Mexico, in the last 48 hours, there are hospitals that don't have a single open bed available. There are hospitals that have no respirators and ventilators available. And there was a period of time in the last 48 hours where literally they shut down 911 service so that because there was absolutely no capacity to serve humanity. The crisis that is unfolding in certain parts of our world is still monumental. But I jokingly tell people, there is not just a pandemic of a virus, there is a pandemic of opinions. But I will say this, and very graciously, quickly, what's so unique about this is because it is a first-time virus that has never infected humanity before, the only alternative that we had was the social distancing. By having folks do the social distancing, in a sense, we are convinced that we have saved thousands upon thousands of lives. At the risk of being a little dramatic, though, in saving lives, we have destroyed the economy. We have destroyed people's security. We have pressed unemployment rate in Southern California to now be pressing 25%. So I get that people are frustrated. I get that there is a plethora of perspectives, but brother, to throw the baby out with the bathwater and say that this is an overreaction, to me, is irresponsible.
Thank you so much, Dr. Nick. One follow-up question to that constituency, to the people that feel that way. One of the biggest arguments that we hear and see is that, hey, this is like the flu. And people die every year of the flu, and we never shut down a building. We never shut down school. People die, and the numbers are high. To be honest, when I hear the numbers of how many people die from the flu, it's actually shocking. I didn't know that. So a lot of people's argument is, we never shut anything down for the flu. Why is this different from the flu, Dr. Nick? And why should we treat this differently and respond differently?
Thank you. As quickly as I can, because this is a once in a generation, if not 100-year experience. The difference between this and even the swine flu that my father passed away from are three simple things. This is a virus that has never in history previously infected humanity. Never. So there are three things that we do not have. Nobody has immunity to this virus, whereas the flu, it is an annual event and there is at least some partial immunity. Number two, there is no vaccine available. As we all well know, though they are not perfect year to year, for influenza, there are vaccines available. And number three, there are no medications whatsoever that are proven to be effective. There are some that have promise, but there are none that are proven. So when you take into consideration that we are fighting a new viral enemy with no immunity, no vaccination, and no medication, the only thing left, and it's the illustration that I use, is to take cover, is to get into the trenches and to hide. And the fact that we have not had that of an experience, even though people are hiding, is an indication that what we did is working. That is not to interpret that there's nothing to see here. And not to be too graphic, but the illustration that I use is, if we have people now hiding in the trenches, you stand up prematurely, you're going to have your head blown off. And so the issue to me is not, I don't want to be dramatic, but I feel like I have to be matter of fact, Pastor, because there is such strong opinions. In the absence of immunity, in the absence of vaccination, in the absence of medication, for a period of time, the only option we have is to take cover.
Dr. Nick, talk to me about the discrimination of the virus. And as you see the stats, as you see the disproportionate rates of, I mean, well, I don't want to pre-assume the question. Are marginalized people, are people of color, disproportionately being affected by this virus?
Absolutely, Pastor. And every region of the country has its own variation in terms of population, okay? And just real quick, here in San Diego, where I am the chief medical officer, 35% of the population is Latino. African Americans in San Diego are not as large of a proportion of the population as they are in other parts of even California, certainly in other parts of Metro USA. Our population here in San Diego of African Americans is about 5.5%. You add Asians and Native Americans, Caucasians are now what's called the, majority minority. It's less than 50%. But let me get to the punchline, and there are two things that I want to say from the perspective of a physician. This virus does not discriminate who it infects. It doesn't care about your zip code. It doesn't care about your color. It doesn't care about your socioeconomic status. It doesn't care about your age. It is an equal opportunity infector across the board. And another challenge is that it is a pretty infectious virus. But it has disproportionate impact. And one thing I just want to say, of course, tonight I realize that we are focusing on racial and socioeconomic issues, but another thing that comes into play is the age factor. And let me illustrate that in terms of here in San Diego. Of our cases in San Diego County who are over the age of 60, that accounts for only 25% of our cases. But when you look at the death impact, 85% of the individuals who have passed away are over 60. So that's number one. Number two, from the perspective of a national, because I give lectures about this now, Brother Tate, and let me share a few numbers. I'd like to share two numbers, one national and one from New York City, where I have a lot of connections and also have a lot of access to data. And again, let me talk about sort of the worst outcome of all of this, if I may. There are many ways to look at it, but let's talk about the consequence, unfortunately, of death. Nationally, the number of African Americans, and I'm going to focus on them for a second, 13% of the cases, but 34% of the deaths.
Wow.
That's out of proportion. Let me talk about numbers per 100,000, which is the way in public health that we typically share sort of experiences. If you look at the mortality rate per 100,000, for African Americans nationally, it's 73 per 100,000. For Latinos, it's 36 per 100,000. And for Caucasians, it's 22. So big difference between 73 per 100,000 and 22 per 100,000. And quickly, because it was such a dramatic experience, New York City. The deaths per 100,000 there, interestingly enough, was actually a little bit higher in Latinos. It was 187 per 100,000. For African Americans, it was 184 per 100,000. And for Caucasians, it was 93. I would imagine in the little bit of time that we have left, I'd love to unpack some of the reasons why. But to answer your question with a little bit of data, matter-of-factly, this virus does not discriminate who it infects, but who it impacts is very much influenced by a host of factors where it is absolutely disproportionately affecting our Black and brown brothers and sisters disproportionately.
Wow. Wow. Dr. Nick, hopefully you could stay on a little while. We've got some other panelists that we'll be able to do. I'm so thankful for your time. We've got pastors who are watching. We've got parents who are trying to figure out school, trying to figure out summer, pastors trying to figure out when to bring congregations back together. Could you speak to us as we're trying to make decisions, Dr. Nick? And to be honest, it all depends on what news channel you tune into as to what direction they're trying to send you towards. So it's a very confusing time politically. Could you speak medically and biologically? How should we be thinking about re-engaging life as we've known it? Church services, summer camp, school in August? Is August, are things going to clear up? Should we be concerned about August? Should we be thinking January? Give us some insight.
Yeah, wow. And what, in a minute, right? So let me say two things. Because the other thing is my heart is bursting to unpack the reasons for the disproportionality, but maybe we'll come back to that later in terms of the Q&A, or others will cover it. But because there are some interesting things to unpack there. But let me answer your question in terms of coming out of it. First of all, and I realize most of y'all are probably in Los Angeles County, right? And Orange County in terms of the folks who are participating.
Yeah, but Dr.
San
Nick,
Diego,
we do have some people that are in different parts of the country.
Oh,
I just
you
got to know
do?
from somebody in
Okay.
Utah, somebody from Texas. So it's not
Okay.
exclusively California. Okay.
Okay. The point of bringing that up is that there is certainly some variation in terms of the experience of what's going to happen in a rural county versus a dense county, socioeconomic county. All of those kinds of things come into play. But let me say this. At least in California, if I may, I'll focus on that a little bit for a moment. The decision ultimately, and this is what's very controversial for some people, really is now out of Sacramento. And it's going to be influenced by data. The problem is, going back to the analogy that I used before of all of us, quote unquote, hiding in a trench. We all got into the trench pretty quickly and pretty much at the same time. We will not be able to all get out of the trench and back into it at the same time. This is a two-part consideration. We're concerned about preserving human life, but we are also very concerned about the capacity of our healthcare system and making sure that what is happening right now, frankly, in Tijuana, I never, ever want to see happen anywhere that I'm involved with, and certainly anywhere in the United States. It's unfair what's happening in Mexico, and I feel terrible about that, but I'm doing everything that I can to prevent that from ever occurring here. As such, the plan is for us, where we flipped the switch and everybody had to get into hiding. The plan on the other side now is really for it to be more methodical and for us to kind of turn down the dial. You almost see our governor kind of releasing, one little thing at a time. And sometimes it's nothing funny, but, like things get called out, like yesterday was dog groomers and, very specialized kind of things. The next thing that people are waiting for is restaurants and dining in and so on and so forth. But to your point, Brother Tate, and this is tough, for me, and I realize, I know yours is a large church. In many ways, it's like a mass gathering. Until we have a vaccine available, until then, which is probably a minimum of 9 to 12 months away, we will have to have the capacity, in order to protect the most vulnerable in our communities, to modify the way that we do life to, even if we are congressionally and congregately together, to be able to maintain a level of social distancing. If that cannot occur, personally, for as shocking as it may sound to some people, mass gatherings will not happen responsibly. And what's so tricky about this virus, which I think a lot of people don't understand, is another big thing that's different than the flu, by the way. The flu, the incubation period, meaning the time from when you get infected to presenting symptoms and getting sick, can be as short as 2 to 3 days. What's brutal about this coronavirus, it can be 10 to 14 days that you have zero symptoms. And
Wow.
that whole time, you can be sharing the gift of that virus with grandma, with your uncle who's got cancer, with your nephew who's got asthma, with your sister who's got diabetes, without even knowing it. And so until we hit that point where there's a protection, the only thing that we have left is the ability to cover our faces on both sides, facial coverings, and to maintain social distancing. And until a vaccine is available, personally, we risk, and it's very hard when we talk about the disproportionate impact of the population, especially on the elderly, we risk having very detrimental consequences. And it just grieves my heart to consider that people are still of the mindset that this is a conspiracy, when in reality, we have the experience that we have because we've taken the interventions that we have.
Dr. Nick, I am so grateful. That is, I mean, my heart is just beating fast. I'm so full. Thank you so much for that insight. And hopefully we'll come back, because I'd love for you to unpack some of those disproportionate numbers. And we've got some other panelists that are going to speak to that. What I love is that, Dr. Nick, you are not a politician. You are someone that's sitting on the front lines. You're seeing the families, you're treating the patients. So your perspective has been invaluable. Thank you so much, brother. And hopefully we'll come back. John, I hand it off to you.
And if you're just joining us, please put your city of where you're watching us from if you haven't already done so. Now we're going to have Dr. Dawn Ward. Good evening, Dawn. How are you? We can't hear you. Hold on.
There we go.
Ahead. There
now
we go.
Right?
Yes, and let me say before we get started with you, Dr. Dawn and I were in a life group together for a little over a year, so she's an amazing person. She's an amazing mom, wife, and obviously doctor, so welcome this evening.
Thank you, John.
Yeah, so we're going to have you talk to us a little bit about history in medicine. And so I like to start off by asking you, do you think that it's important to place what Black and Brown people are experiencing during this crisis within a larger historical context?
Oh, most definitely. So when we look back at the experiences that our Black and Brown brothers have experienced just in the past, there's some atrocious events that have actually happened. And we don't really, we definitely don't learn about these things. I did not learn about them in medical school. They're not in medical texts. But when you actually look back into the history, you do see different events that have occurred. And I have 4 different events that I wanted to share with the group today that kind of give a perspective of some of the racial and health disparities that have occurred over the years. So if you could cue up my slides, I'll go ahead and get started with that. Thanks so much. So this first case that I have, and as I mentioned, these are just cases that I've selected over the years, but I wanted to definitely start with this one. This represents Dr. James Marion Sims, and this was in the mid-1800s. And Dr. Sims was a plantation doctor, and so he had access to all the slaves if they were ill or if they were in childbirth. And Dr. Sims actually is labeled as the father of gynecology. Now that title has been stripped from him, because when you look back into his records, what we discovered was that he was, although helping these slave women through childbirth, he was experimenting on them essentially, and they were really voiceless and were unable to not undergo these horrible experiences. So Dr. Sims was known to perfect this procedure with a fistula, and a fistula can sometimes form during childbirth. It's essentially a cavity between 2 different spaces, like a tract that forms. And so after childbirth and after traumatic childbirth, a fistula could form between the vagina and the bladder, or the vagina and the rectum. And so Dr. Sims would essentially operate on these slave women. And so the challenge with this is, though, that these women did not have anesthetics. This was back in the early 1800s. There was no anesthetic available. And so he would actually perform these procedures on them repeatedly. Several people died from sepsis. And it was just a horrific thing that occurred to women, slave women during this time that were voiceless. If you go to the next case, I wanted to highlight just with medical schools and actually medical training. So I have 2 kind of images that help demonstrate during medical training back in the 1800s, all the way into the early 1900s, where slaves were, as they passed or became deceased, their bodies were actually taken and used as cadavers for medical training. And it actually brought up this term body snatchers, because there were people that were hired to steal these bodies of slaves to use them as cadavers in medical training. And so here, this just demonstrates an article that was featured in the New York Times back in February of 2018, just explaining this slave trade or cadaver trade, as you will. And on the next images, as you can see, and they're a little graphic, so I apologize for that. But you can see that we have, these are likely physicians here and potentially body snatchers as well. And here they are essentially doing autopsies on bodies, Black and brown bodies, because these were the bodies that they were essentially stealing and using for medical training. And then let's go ahead and go to the next slide. And I just wanted to demonstrate here. Oops. Is there one back? If not, then I'll go ahead with this one. Okay, let's start with this. So this is, I'm sorry, go back to the syphilis, the Tuskegee Experiment, if you can. Thank you very much. So most people are more familiar with this study. This was the Tuskegee Experiment, which actually began in 1932. And it actually began with very noble intentions. At that time, syphilis affected about 35% of the population. And participants were included in this study. There was about 600 of them. And of that 600, about 201 of them were not treated for syphilis. So at the beginning of the study, there were some things available for treatment. It was terrible treatment, but there was something available. The treatment was very toxic and also could be fatal, excuse me. And soon after that, the Great Depression hit. The financial stability of the study waned. And the new focus of the study went towards not treating people that had syphilis, to kind of follow them over the years. So it was essentially a natural history study. In 1947, syphilis became available as a treatment for syphilis. However, the participants of this study were not given the option of that treatment. They were likely misled. They were ill-informed as well. And so there were participants on this study from the beginning of the study through its year of termination, which was 1972, that were not provided treatment to essentially to treat them for syphilis. And as you may or may not know, syphilis is a progressive type of disease, a progressive infection, and the later years of syphilis is truly adverse. It can cause cardiovascular and neurological complications. It's really horrific. And these people were held treatment. Now, in the 1960s, this study was still ongoing, and it was supported by major medical associations. And it wasn't until 1972, when news articles began to condemn the study, that it was actually terminated. The last study participant actually passed away in 2004. So, over 40 years, the study was ongoing. People were withheld treatment, people were misled, and truly horrific time in medicine. And then let's go to the last slide that I have, one of the last slides that I have, so you can move forward. So this is Henrietta Lacks, and in 1951, she was just 31 years of age, and here she is with her husband, but she died from an aggressive form of cervical cancer. It was described as a knot within her womb, and she presented to Johns Hopkins for treatment for this cervical cancer. Now, little did she know, the cancer cells were harvested at that time, and they were essentially grown in like a cell culture. And these cells are now are known to be immortal cells. They were very different and behave very differently from other cancerous cells from people. The cells were so immortal, and they were able to culture them over and over again, they're given the name the HeLa cell line. And they were sent across the world to different researchers to be able to just work and experiment with these cells. And Henrietta Lacks and her family did not know that, of course she had passed away, but her family never knew, even after years, that these cells had been taken and were being used in medicine. And I wanted to just quickly highlight some of the findings from these cells from this woman. These were the first human cells that went into space. They were the first cells that were successfully cloned. And here you can see a picture, like an electron micrograph of that there. These cells actually helped eradicate polio. So these were the cells that were susceptible to the polio virus, but the cells actually weren't killed by the virus. So they were the first host cells to help make a vaccine for polio. Additionally, in 1984, these cells, which were still around because you can continue to grow them over time, these cells actually helped determine the etiology of cervical cancer, which is by a human papillomavirus or HPV-18. And so they were able to use that and come up with that from the cells. And then lastly, fortuitously in the lab, there was a mix-up, and the researchers were able to stain and see the chromosomes of the cells. And so this HeLa cell line is actually was one of the beginning cells to help with cytogenetics and understanding 23 chromosome pairs, and moving on to learn more about medical disorders such as trisomy 21. So those are the HeLa cells. Now, just beyond the research and in the general practice of medicine, and Dr. Nick did touch upon this a little bit, but I want to just demonstrate the different health disparities that are ongoing today. So if you can move to the next slide, please. I'd like to just show you the mortality rate. So I'm not sure. Oh, not that one. Okay, so these are actually different slides, but that's fine. So I can just touch upon. I'll just touch upon what I wanted to just let the group know here. So maternal mortality rate for African American women is 40 out of 100,000 people. For other people, other races, I'm sorry, it is less than, it's about 17, so less than 18 per 100,000 folks. And for white women, it's about 12.5 per 100,000 people. So there's definitely a disconnect between races and just maternal mortality. Secondarily, when you look at the data from the National Cancer Society, when you compare African Americans and whites, the death rates in African Americans is disproportionately greater than for whites in almost all cancers. So that includes colorectal cancer, prostate cancer, breast cancer, and just all sites in general. So there's definitely something going on. This is not something that's made up. There's definitely something going on, and it's killing people of color. And it's just something that we really need to understand. And then lastly, one thing I was going to share with you was just an article taken from Emergency Medicine Journal. And essentially these physicians, these emergency medicine physicians, followed African Americans and white and kind of compared them. And they recognized that African Americans were triaged differently than whites. African Americans were held in the treatment, were not provided treatment as quickly as whites. So even as you present to the emergency room, there's disparities that are occurring at that point. And health disparities in general is very, very complex. There's several layers to it. There's implicit bias and health literacy and comorbidities, just the social aspects. So there's lots of things that lead into it. But it is definitely something that does exist. And then I just wanted to make one last statement. And this is taken from a book called Medical Apartheid that I read by Harriet A. Washington. And the author writes, in our nation, race is important to discuss for health and disease, but biological race does not exist because all humans share the same genes.
Thank you so much, Dawn. That's really good. I'm glad we're able to kind of pull these strings and tie them together. We're going to have you come back on a little bit later to ask some follow-up questions. But right now, we're going to take a short, kind of a slight break. So attendees, participants, we're going to ask you 2 more questions. So we're going to put up a couple more poll questions. The question is, when you hear about these health disparities that are taking place, how does that make you feel? And then the second question is, what's the largest contributing factor to health disparities in your opinion? And so we want to just kind of get you to be able to participate. And one of the things as you're answering the poll questions that we look at here at Fellowship is we believe in a whole gospel for the whole person. And so that's body, spirit, soul, and mind. And so that's why we, with all of our events, we always ask, how are you feeling? And how are you thinking? And so that's why we have these poll questions. So if we can, I guess we'll start to get some of the results. And so 65% angry, 60% sad, 10% numb, 4% surprised, and 15% other. And then the response is implicit bias in the medical system to your second question, overwhelmingly 7%. So thank you so much for participating. We're going to ask a few more questions down the line. But right now, our next set of panelists are Pastor Joseph, Pastor Alexia, and Pastor Rich. And as they're coming on, again, we want to thank everybody for joining us tonight. If you haven't put where you are from, what city you're from, please put that in the chat. We really want to know where everyone's coming from. And so I'm hearing some noises. I think that's Pastor Joseph. I'm gonna ask you the first question. First, Pastor Joseph, just a preliminary question. Where are you talking to us from, and what church and are you with? Do you pastor? And then also, what tribe are you with?
Yes, hello, Dangote. First of all, I'm Apache from the Indian Nation in Chiricahua, New Mexico band, and I have relatives in Mescalero Reservation and also in Hickory. And I'd like to thank everyone for inviting me to this panel. I was for a long time, when I first started Native ministry and became saved, I was with First Nations Foursquare. I went through their Bible study and became a pastor as well. And I've been working all these years in the Native community, taking the Word of God there, and it's been a real blessing. And we do, we had a lot of breakthroughs. We worship traditionally, and it's just been amazing.
That's great. That's great. I'm sorry. Let me ask you. So you work with the indigenous community. Can you tell our audience how COVID-19 has impacted the communities that you're working with?
Yes. At this time, what I want to say is that the ones mostly impacted are the the Native Americans that still live around here in the reservations. It's some of the places it's hard to reach. Medical attention is not nearby, and equipment is not as great or abundance as the cities. And right now there's a great concern because Navajo reservation, they shut down the reservation and they only are letting folks that live there, and the Oglala Sioux tribe as well. And we're concerned because the communities there have there's no jobs, and there's no they live below the poverty level, especially in finances. And that's why everybody moves away to big cities. And there's another community that we call ourselves urban Indians, which is the Native American urban. They're in Seattle, LA, Chicago, and we work like everybody else, but we kind of blend in with the Latino. Some folks think we're Latino, but until they ask. But historically, you know, we have through because our history is oral, most of it, and ever since Columbus landed in 1492, I mean, 90% of indigenous people in America with diseases and the killings, it brought down the population to 90%, which is about 50 million or so. But we have, you know, experienced in the past what it is to be devastated by, you know, a disease or a pandemic, and especially, you know, during the Indian Wars, also some of it was done intentionally. They would give us infected blankets with smallpox, you know, because, you know, it was just that's the way it was in those days. You know, war is just terrible. But that's why when we give blankets, we give them with love, and we understand what the significance. You know, when you give a family a blanket at a powwow, and we wrap each other, and we remember those days. But right now, you know, it's just really, we're really worried, and especially for our folks that live in remote areas. Excuse me. You know, my wife, when they had the tuberculosis pandemic over up in Alaska, because she's from up there. She's Inuit and Haida, and her mother had a full-blown tuberculosis, and she didn't speak English very well. So when my wife was born, they took her at birth and put her in a I don't know what denomination it was, but it was sort of like a boarding school orphanage. Mm-hmm. And they took her from the mom because they were pretty sure that her mom was going to die. And because of the language barrier, she didn't speak English. They just put her for adoption. But her mom did survive. And we reunited with her family, you know, like 10 years ago. We flew back to the village, and it was a wonderful thing. But, you know, Native American community have suffered a lot with things like this. And it's not really new to us, but, you know, we do worry like everybody else, you know.
Yeah. Thank you. I want to shift gears a bit, and Pastor Joseph, I'm going to come back to you a little bit later on. Pastor Alexia, now you work with the immigrant and refugee communities. How has COVID-19 impacted the immigrant communities?
So before I talk about that, John, I want to clarify a little bit about how brown health disparities and immigrant health disparities are related. Because I think a lot of people don't know anything about the racialized nature of immigration enforcement. I just want to give two statistics that help people understand that. And then I'll talk about the impact on immigrants. Roughly a little over half of the people right now who are undocumented in this country didn't cross the southern border. They're people who overstayed a visa. But the way that most people think about immigrants is people that cross the southern border. And you know, the country that has the highest percentage of people for their size that overstayed their visa is Canada, but we don't see a lot of immigration raids and white communities looking for Canadians. The other thing I wanted to just mention was there's about 6 times as many undocumented Latinos as Asians, but 158 times as many detainees who are Latin American as Asian. So it really is affected by race or ethnicity. So now I want to jump in and I want to say what's happening to immigrants under COVID. And I want to talk about 2 areas of impact. First of all, I want to talk about detention centers. Most people don't realize that immigration from Mexico is net zero since about the last 5 years. The people that are coming across the border are not people from Mexico, they're people from Central America, and they're fleeing the human rights crisis. And that means that when they come into this country, they come in to ask for asylum, and they're not illegal. I want to say that again. that if you cross the border and ask for asylum, which is essentially the same as refugee status, you can do that legally. But what will happen to you is you will be put in prison. You will be put in a detention center. You could be let out with an ankle bracelet, and that's something that happened quite often under the Obama administration. When people are monitored, it's about a 93% return of people coming back to court. But this administration doesn't like to do that. You are in prison, you are in a detention center, while they are trying to vet you for whether or not you deserve asylum. The other people who are in detention are people who are fighting their case. Some of them have US relatives, they have some kind of immigration case. Again, they used to be let out with an ankle bracelet. Now they are kept in prison while they are fighting their case, most of them, not all of them, but the majority. So I want you to imagine then COVID is coming, and you have people that are over 60, and you have people with underlying medical conditions, and they are trapped in a detention center, and they haven't committed crimes, the people who have asked for asylum. They're just being held in a detention center. Now, Great Britain, when COVID hit, decided that they would review all of their immigration detainees. They would review all the cases, and people that were not a threat to the public safety, the threat to public safety would be let out. Our administration, our acting director, said that he would not review any cases. So a lot of us got busy very quickly, and there was a letter signed by 25 of us who are national Latino leaders, and we sent it through our Congress people, and there was a miracle, and they did decide that they would start reviewing the cases, but they started reviewing them very slowly. And so what does that mean? I want to talk about a good story and a bad story very quickly. The good story is that we have a young man who's an unaccompanied, he ran as an unaccompanied minor from the human rights crisis in Central America. Young men are particularly targeted in that crisis. He was in detention here. He has severe underlying health conditions, and they let him out. And he is being cared for now through one of our support circles of various churches, and he's getting the medical treatment he needs, and he doesn't have COVID. So thanks be to God. In that case, they reviewed his case and he was released. But we have a Christian leader, a church leader, who is in detention, and we began to advocate. His father-in-law is a pastor. We began to advocate for him, and the case just kept moving really slow, and he has severe underlying health issues. And they were telling us, oh, we're going to decide it next week. Well, he went 2 days ago. He left detention into the hospital. So this is a man that has not done anything that should be a death sentence, and yet that may be what he is facing. So the other injustice that I wanted to talk about with immigrants, our immigration system is badly broken, so which I don't have time to get into right now, but it means that there are many people here who fight cases for many years, and who are undocumented, who don't have social security numbers, but they can, if they start a small business, and immigrants start small businesses at a higher ratio than non-immigrants. So they start a small business, they can get a legal business license and a tax number, and they pay taxes. They can pay taxes, and they do pay taxes. But all of the benefits that were coming down from Washington for small business, people specifically excluded people who did not have a social security number but had a small business tax ID. So these people have been paying taxes faithfully, but they're not included in any of the benefits. And not only are they not included, their families, if they have citizen spouses, their citizen spouses are not included in any of the benefits. So it's really mean-spirited in a very deep way. Now, California, thanks be to God, is quite different, particularly Southern California. And our local government is trying to make up this disparity. But all over the country, for us in our community, the public health issues and the economic issues are profoundly connected. So that's the heart of what I wanted to say. I think maybe there's one other thing I just want to say, which is that going to get healthcare for immigrants is very frightening, not only because if you're undocumented, you worry about being caught, but it's also very frightening because there's something called public charge. Even though public charge is supposed to be waived for COVID testing, but immigrants don't trust that, and history shows that it's not trustworthy often what the government says. But if you go to get help, they can call you a public charge and then you can lose your case. So just wanted to name all of that.
No, I appreciate that. Thank you for stating that. I'm gonna come back to you a little bit later on. I'm gonna jump to Pastor Rich for a moment. Pastor Rich, good evening. Welcome from New York.
Hey, John.
Now,
good to be here.
Hey, you are a pastor of a multi-ethnic church, and you're in the epicenter of this virus. How's that been for you and your church?
Yeah, for me, I have a 5-year-old son, Nathan, and earlier this week we went for a little walk around the neighborhood, and we passed by the park that he usually plays at, and it was all locked. The playgrounds are locked, and he said to me, "Wow, Daddy, the world has changed. This feels like a dream." Now, I laugh because he's 5 years old. What does he know about the world changing at all? But I think he articulated what we're feeling. The world has changed. This feels like a dream. And so how it's been for me, well, it's been emotionally draining. Lots of stories of deaths and intubations and financial strain. Over 20,000 deaths in New York City and Queens. I'm in Elmhurst. I'm 1 mile from 1.5 miles from Elmhurst Hospital, where I live. Our church is less than a mile from Elmhurst Hospital, which has gotten a lot of attention in the media in the past couple of months. And so we are aware of lots of death. And so it's been painful. As a pastor, I've been in many phone conversations with grieving people who can't gather with friends and family to grieve and mourn and experience the longing for embrace in these moments of significant grief. And so it's been quite draining. Our church, we've lost one person, and just in terms of our church is about 1,800 folks. So we have one, but we have heard plenty of stories of relatives of congregants who have died. And, I know personally about 6 people who have died. But I mean by that, friends, mothers of friends and all that there. And so it's been quite overwhelming to say the least. And I think what pandemics do is, and crises like these social crises tend to reveal what's often hidden, which is namely the stories and lack and limits of socially marginalized and overlooked people. And so I read an article this morning in The Atlantic from Calvin Baker, who said that the virus doesn't discriminate, but the world we occupy does. And I think about the way it's impacted our church and our particular neighborhood is, Queens, first of all, half of Queens is foreign born. And so our zip code at one point was the most diverse zip code in the world. I'm not sure if it's still the same. And our claim to fame beyond that is just our church building is in Coming to America, by the way, in the movie. And so we're in the background of Coming to America. So next time you see Eddie Murphy cleaning outside McDowell's, our church is right in the background. So that's our claim to fame. But we have 75 nations represented in our church, 123 languages spoken at the nearby hospital, Elmhurst Hospital. So it's incredibly diverse, and not just ethnically, racially, but socioeconomically as well. And what we've seen in our church and outside of our church locally is that the access to resources and information was incredibly limited, especially for non-English speaking people. And so these social crises reveal just the gaps in terms of how we serve people in marginalized spaces. And I think there's just one story that I think encapsulates this. One of our pastors, his name is Red. He leads our Community Development Corporation. And upstairs from his apartment is a mother who has a daughter named Brianna. And her mother went downstairs to Red and said, "Could you print out for me 15 sheets of classwork for her daughter, as everyone is homeschooling these days?" And he happily did so. And he thought to himself, why is the teacher asking parents to print out paper? I thought everything was supposed to be done online. And so after some questions, he asked Brianna's mother, and she said, well, it's hard to do this homework and help my daughter with homework on my phone. And so it was evident at that point that she didn't have a laptop, she didn't have a tablet. And so Red calls the teacher of Brianna and says, can she do her homework on a phone? She says, no, it's not really possible. So Red does some more research and finds an organization who's giving out laptops. So he gets a refurbished laptop, but she doesn't have Wi-Fi. And so he now has to do some legwork, finds out the Department of Education now wants to give out Wi-Fi ready devices. And so does some more legwork on her behalf and finds a hotspot. And now Brianna's mom is going to have a nice phone bill. And so here it is. I mean, the implications and consequences, often that's not seen. We see the deaths, we see the intubations, we see the illnesses and such, but it's often these other cases here that we miss. That poverty is not just about someone sleeping on the street. Poverty is also about, and being under-resourced is, Brianna can't get Wi-Fi. And so I think it's these stories that we need to call attention to. And then the question is, what is the church's responsibility in these contexts to work for justice and partner with local agencies and such to see that those who are overlooked and under-resourced to get the help that they need. And so that's a story that I think encapsulates some of the hidden poverty, the hidden pain, the hidden disenfranchisement that folks have experienced, particularly in Queens.
Yeah, it's as you're telling that story, I was thinking of James Baldwin's quote about how extremely expensive it is to be poor. And so I mean, that's a sad and amazing story. Let me ask you one follow-up question. What is your church, what is their response? And what have you guys been doing kind of on the ground as a church community?
Yeah, as a church community, I take Genesis 1 and 2 seriously. And I think the first two questions that God asks in Genesis 3 and 4 rather, are instructive. When Adam sins, the first question he asks is, where are you? And then when Cain sins, the first question God asks is, where is your brother? And I think those two questions really get at the heart of Christian witness and Christian ministry. Where are you and where is your brother? And I think to understand who we are, we have to understand who our brother is as well. And so there we are intrinsically connected to each other. And so because we have held that to be true, we've done a couple of things. Number one, we've kept our health center open. We have a community development corporation that's been patterned after much of like the CCDA movement, John Perkins and such. And so we have a health center that sees close to 2,000 patients a year, mostly immigrant, undocumented, no insurance. And so we've kept our health center open for day laborers and many of the homeless men that come in for showers and food and to get checkups and such. And so we kept our health center, we're socially distancing and such, doing everything in the right way. So we kept our health center up for the overlooked population there. We've also, we wanted to let the community around us, particularly Elmhurst Hospital, know that we have a ministry of hospitality. And what that means is we have a fairly sizable building for New York City standards. And so we immediately filed paperwork just offering our facility to open up a big space to support healthcare workers, nurses, doctors who might not live in Queens, but need a space to sleep. And so we went through that process immediately, and we are in conversations with the city, but we have already agreed we're going to do that. It's just on the city whether they're going to do that or not. But our goal is hospitality in the Benedictine monastic way. We want to receive every guest as Christ. And so that's the second thing we did. We also created a COVID relief fund to support congregants. And so again, we have a socially, economically diverse community. And so we created a fund for those who just need some financial support. And we also partnered with another church to do a couple of things. There's small businesses in Queens, lots of small businesses. Again, half of Queens is foreign born, lots of immigrant owned to the previous doctor's comment about just immigrants starting small businesses and such. And so this fund as well is going to purchase meals to help businesses stay paying the bills and keeping the lights on and paying their workers. and also provide meals for nurses and doctors and medical staff at Elmhurst Hospital as well. And so those are a few things that we've been involved with over the past 6 to 8 weeks.
Wow, that's a lot. That is a whole lot. And God bless you for the work that you and your church are doing. That's amazing. We're going to come back to you. So I'm going to put you on pause for a moment. I want to bring in Albert to join me in this next section. So I'll wait a moment for him to come in. And we're going to look at kind of how Scripture informs us. And Albert, if you can kind of help us to help me to co-lead this section, that would be great. And
Great,
so,
John.
yeah.
This has been so amazing so far. I mean, it's been so powerful.
Yeah, let me jump to, let me ask Ricky first, Pastor Ricky. How can the church respond to this crisis of health disparities? I mean, Pastor Rich gave us such rich things already, but from your perspective, how do you think we can, as a church, respond?
Yeah, John, my heart is stirring. I've enjoyed everybody that's spoken into this conversation thus far. Obviously, the answer to your question is worthy of a library worth of books. But I think tonight's a good starter for how the church can begin the process, and that is to assume unawareness and heed God's call to be responsibly Christian, responsibly biblical, and know the relevant conversation, know the relevant data, become aware, to have a posture of humility, to assume that we don't know everything, that we haven't read everything, that we haven't met everyone, and engage in conversations much like the one we're having tonight. Proverbs says that only a fool listens to one side of the story. And too many of us in the church are very guilty of listening to one side of the story, whether that be theological, whether that be scientific, whatever the case. There's a lot of arrogance there that we're blind to. And so I would say the church should probably lead culture in knowing what's going on, to know who it's happening to, and to invest in deep engagement and a partnership of relationship with all of these demographics. When I read the Bible, I see the New Testament witness. Pentecost comes, the church is born, and immediately after the gospel spreads outside of Jerusalem, they immediately engage in these multi-ethnic, multilingual churches under the banner of Christ. And it seemed that from its onset, the Christian church understood that this gospel is really not relevant unless it engages everyone. And it appeals to God's heart to assume partnership, relationship, spreading this gospel witness to not just people who look like me and think like me, but whoever my neighbor may be, to Pastor Rich's comment earlier about who is my brother. So my answer to the question, and again, my heart's still stirring, dude, so I need to sit on what I've heard over the last hour. But the first thing is to become aware, and in light of that awareness, now pursue what the information compels you to do. That's my first blow at that. I'd love to hear what Pastor Albert has to say about that too.
Yeah, no, John, this has been so rich, John. I think this is a powerful opportunity for the church, not just our church, but the Big C church. What Rich just talked about, what his church is doing, Pastor Joseph, everyone, Alex, everyone has said so many profound things. Here's the tension, and here's what frustrates me, what burdens me, but what ultimately makes me sad. I've got a white pastor friend who's a part of a coalition they've literally made videos advocating that we need to come back together to worship. We need to open the state up, which is fine. But in that, there's also this assumption that this is kind of not real. This isn't really real. And the world has been hoodwinked and bamboozled by the media. And I just thought, as I look at him leading his white church, and as I'm standing here as a Black man leading my multi-ethnic church, How is it that we can sit in the same world and have such drastically different experiences? Like I'm seeing the funerals, I'm hearing the testimonies like what Rich just gave, and I'm seeing the death total, and I'm seeing people that look like me. My mom had a scare where she had a coworker that had it, and we thought she had it. Well, my mom's a Black woman who's over 60. I'm praying to the Lord, my God, that he would spare her life. She tested back negative, everything was fine. But it's a crisis for me. And here my white brother is almost saying it ain't even real. They're putting up these memes that show stats of how the numbers are so minimized. And they may be minimized, but those numbers are people that look like me. So it affects me differently. So I think Pastor Rich, he said it so profoundly. Where are you and where is your brother? And what I'm missing in the macro conversation is a lack of people saying, where are my brothers and sisters who are of color? Where are they? Where are the immigrants that have come fighting for their life, trying to come to America so they can be saved? Where are they now? I had no idea. I've been so enlightened, even about the detention centers. You know, you kind of have nobody, but to hear the real life stories, it's our job as the church biblically to ask that question. And what breaks my heart is what I've seen is several of my, I'm just gonna be honest, I'm just gonna be real. Several of my white brothers who are pastors and leaders, they're asking the question, where is my congregation? But they're not asking the question, where are my brothers and sisters? And when we broaden the question, John, we get a vastly different answer to that question. And it's the church's responsibility to ask the bigger question. And I'll just say this too, because I'm the pastor, I can take more time than anybody else. But y'all probably still cut me off anyway. I know that. The other thing is, you know what depletes me and what sometimes makes me want to throw in the towel is the burden of having to defend my pain and the reality of our people. To sit and say, you got to prove it for me to believe that it's real. Because there's an assumption that my tears and that my burden and that my reality is not real. It's not real. And the pain is real. The death is real. The disparity is real. And it's been real a long time. And it is important for the church to take a posture of empathy in inviting God to say, what can I do? Just like Rich talked about the young lady with no internet. Already somebody in the comments said, here's my phone number. I want to pay for her internet. That's what the church is to do. And when we can hear of one another's burdens and not make them try to defend their burdens, then we can help carry one another's burdens. All right. That's it. Go ask another question, John, before I start preaching up in here.
Let me go back to Ricky. So Ricky, I want to piggyback off of what Albert just said. What do you wish our white or non-people of color congregants would understand or acknowledge?
Yeah, I think there's a repentance that has to take place. That could probably get me in trouble, but you know, I don't care. I think with respect to what we talked about with becoming aware, and when you just take a stroll down history lane, as Dr. Ward did so skillfully about a half hour ago, and learn the history of the injustice, the history of the conversation, the presence of bias, systemic injustice that persists and pervades culture today, I think there's a repentance that has to take place. And I think it's from a posture of repentance where we now know, okay, what does it look like now to pursue these relationships and to start to move forward? I've got a good friend in San Diego whose church has just decided, you know what, we're going to take our time reopening Southwest Church where I am, we're going to do the same. We're going to take our time because we want to be responsible to taking care of our community. And this is a white guy, mega church, love him. And he's talking to me about some things. And he says, well, you know, there's this about this, and the politics are saying that, and this is saying this. He's like, what are you guys going to do? I said, well, we're going to move slow. We want to take care of our community. And I said, plus I'm Black. And he said, what's that got to do with anything? I said, I'm pre-existing. I'm a cancer survivor. I'm African-American. My mama, my Madea, and my grandmadea got diabetes. I ain't messing around with COVID. And that crushed him. We're friends. He had no idea. He'd never heard it that way. And he went and told his church that same weekend, you know what? Knowing what's going on with Black and brown communities with COVID was a fact that was in my head, but it was not a feeling that was in my heart. And I'm taking a roundabout way to say that the only reason he could have that kind of information, that kind of conviction, was because he's got a friend that doesn't look like him. And so I think I would say to the church, what does it look like for us to make sure that, just like in the pages of the New Testament, that early community had friends that didn't look like them, didn't speak the same language, but served the same God? What does it look like for us to copy and paste that same witness in this moment? So we're complaining about everything that we lost in COVID. We lost money. We've lost comfort. I hadn't gone out to eat in 2 months. We lost movies. We lost this. We lost that. And I get it, and I feel it too. But the church is not doing nearly enough time. We're not taking nearly enough time to celebrate what we have gained. And what we have gained is a moment to seize a viable Christian witness that bends over backwards for your brother and for your sister that is hurting and that is in pain, that can make Jesus famous right to the now. We have done, and I know there's hundreds of churches that's represented right here on this call. I bet every last one of you can say that I felt more like a New Testament Christian in the last 2.5 months than I have in the last 2.5 years, simply because we're in crisis and the gospel looks great in crisis. And so I would say that there's a repentance that needs to take place. And from that ought to just move your heart to pursue these relationships that move facts out of your head so you can engage the feelings in your heart.
Wow, that's powerful. That's really powerful. I want you to be on pause for a moment. I want to bring in Alexia real quick. There's a question from the audience that's come up a couple of times, and I want to make sure this gets answered. Alexia, so the audience is asking, how do the number of COVID cases and deaths reflect the Latinx community when it comes to legal residences versus immigrants? Let me ask it again, and I'll go a little slower. So how do the number of COVID cases and deaths reflect in Latino cases when you're comparing it between legal residents and non-legal residents?
Well, I really need to say, John, that there's no clear data on undocumented people because undocumented people live in the shadows, right? So my assumption always is that a lot of our undocumented brothers and sisters are not being included in the statistics. Mm-hmm. But some of the stress-related health conditions that our people have that make you more susceptible to COVID, of course we all have, right? Anybody who deals with discrimination. One of the realities in the Hispanic community is that when Ricky was talking about knowing people, even if you were born, I was born in this country, my parents were born in this country, my grandparents came to this country, but I have relatives that are undocumented, right? And I have, and I know people in my church who are undocumented. So, you know, we know each other as members of the same body. If my hand hurts, I hurt, right? And my body's not well if I don't feel the pain in my hand and respond to it. So I think that that's the difference in our community, is that we don't make that separation. But I don't have statistics because I think it's going to take a long time actually to see the big picture of everything that's happening here.
Yeah, thank you. Let me jump in, bring Dr. Nick back on. There's a question, another question. Dr. Nick, we're getting this question a lot from the audience. A lot of people would like to hear, actually there's two questions. One is they would like to hear the reasonings for the disproportionate impact of the virus. And then before you answer that one, I think you can answer the second one a little bit easier. there have been a number of parents who have put in the chat, would you recommend your kids going to school this fall?
My answer to that is going to be the following. I pulled my girls out of school before the school closed because I had a very strong sense of what was coming. In terms of putting them back into school this coming fall, I haven't made that decision yet. I have relationships, obviously, with the school leadership, and it kind of depends on the goodness of the details. I have a feeling, folks, that if there is going to be in California, quote unquote, in-person schools, I have a feeling, and this isn't a promise, but it's a scenario that I've been thinking through, is that I think kids are probably going to go to school in a staggered way, so that you might have either 2 or maybe even 3 shifts of kids going to school for maybe 2 to 3 hours, a shorter school day, and then a partial day at home. So it would be kind of a hybrid between in-person and at school. The goodness is in the details. Some of the California state universities, like the Cal States, have already announced that their fall classes are all going to be virtual. Again, even though there's some issues brewing with children now that are new kind of emerging autoimmune diseases, the issue to me isn't just about the kids. It's about the kids potentially bringing home the virus to parents and grandparents and so forth. So the goodness is in the details. I will admit I pulled my kids out from school sooner than the schools closed, and I will be very cautious allowing them to go back to school as well.
Thank you so much for answering that. Literally, there are about 15 people who had asked that question. So clearly a lot of people are concerned. So jumping back to that, my first question, some of the reasons from your perspective on the disproportionate impact of the virus on these communities we're talking about.
Yeah, and again, in the spirit of efficiency and humility, and it breaks my heart to even have to talk about some of this, but it is hard and it is real, and it builds a little bit on some of the things that Dr. Ward referenced, because unfortunately, some of this is institutionalized, but I also believe that there are some consequences that are unique to this specific pandemic. And I had a feeling, being on the line with a lot of pastors tonight, that my time was going to be a little bit crimped. So I actually thought this through ahead of time. And I came up really with 3 categories that I would say that have, in my opinion, I would stand behind this, I would publish it, I would lecture it, and I would say the following. As far as the disproportionality, I would put it into one of 3 of things. Number 1, there's an increased risk of our minority brothers and sisters getting infected. And I can unpack that, but I'm just going to list some scenarios pretty quickly. I do think that there's a disproportionality of Black and brown brothers and sisters having essential jobs, having jobs that are still required, that are lower paying jobs, but that are jobs that are required to be in person, support jobs and so forth, that they have to still go to, and as a result, they risk higher infection. I also believe that there are minority populations that are more dependent on public transportation. And in the context of public transportation, there's also more exposure and more risk of coming in contact with other people. And then thirdly, again, having grown up in New Jersey and New York, and having gone to college, and that's how I know Albert, is through Azusa Pacific University in LA, I would put the third category under risk of infection being higher in the dense housing. I think if you look at either subsidized housing or the social, cultural dynamics, that you've got multi-generational individuals living under the same household, Again, much could be said about this, but I would broadly say that certain minority populations are more likely to be densely living and densely housed, especially those in public institutions and public housing and so forth. So the nature of essential work, potentially exposures from public transportation, and then dense housing, I would put it in the first category of an increased risk of infection. Secondly, back to Dr. Ward's points, are the institutional issues related to poor access, biased access, discriminated access to healthcare. And again, I think enough was said about that I'll just put that into that broad category. But besides healthcare access, I would also include a bias and an inadequate access to testing. You know, the availability of testing in certain communities in comparison to others is more limited. So I would put that into the healthcare category, but it really is a diminished issue with regard to access to healthcare, healthcare screening, healthcare provision, and so forth. So that's category number 2. And then category number 3, again, was referenced already, is the unfortunate reality that because of chronic disease, because of that disproportionality that is already built into it, if you've got a higher risk of infection, if you've got inadequate access to services, unfortunately, there's a disproportionate impact if you do get infected in terms of how it's going to affect you. And the fact that individuals who have underlying metabolic problems, that have underlying heart disease, that have higher risk of certain kinds of malignancies and other things, all of those things added up together, frankly, and at the risk of being a little edgy in saying this, I'm actually surprised that the disproportionality is not even worse than it already is. So I put it in the category of risk of infection, inadequate access to services and care, and then an underlying risk profile that makes individuals who are Black and brown more susceptible to having adverse consequences. Thank you, Brother John.
Yeah, thank you, Dr. Nick, for wrapping that up so succinctly. Albert, I'm gonna give you the last word.
Well, I just want to thank everybody. I feel like we're just getting started. It's an amazing conversation. I would just encourage us as followers of Jesus Christ, as the Church of Jesus Christ, if we could just start putting into practice, asking the question, where are my brothers and sisters? Like Jesus asked Cain, where are your brother? Where's your brother? If we could, as we think about even how we feel about getting out of, coming back and getting business going as usual and opening our churches and all that, let's ask the question, what is the impact of this decision going to have on the marginalized, the poor, and our brothers and sisters of color? And I think it's important for not just people of color to say that and ask that question, but for all God's children to ask that question. Because if we can start asking that question and wrestling with the answer in love and community, we can begin to change the world. And the coronavirus could be the thing that exposed some stuff that was already there, but it was also the opportunity for the church to stand against some stuff that's always been there. That's my hope and my prayer for our church and for all churches and for all God's children.
For that. I want to give our wonderful attendees the opportunity to give us the last word. We have 2 more poll questions for you. And as you're answering those, I will have my closing remarks. If you could put the poll questions up for us, Hannah, that would be great. And also definitely thank each and every one of our panelists. All of you have been amazing. This has just been a really impactful evening. A number of you have asked for Pastor Joseph's bio and his information. We will get that to you through email. Unfortunately, I didn't get a chance to get it, and that's on me. I apologize for that. But we'll make sure that we have Pastor Joseph's bio in the follow-up email that we'll send you within the next day or so. So I'm going to close this in prayer, and we'll end on that. Thank you again for everybody who participated. This has been an impactful evening. Thank you so much. Father, we just want to thank you for your kindness and grace. We thank you for your word. We thank you for the history. We thank you that you love us all the way through. Lord, we pray that you would help us to be Christians who will be doers of the word and not hearers only. Help us to organize, help us to collaborate, to help alleviate this pandemic and help alleviate a lot of the pain that people are feeling. We thank you for all of this in Jesus' name. Amen. And I want to say good night to everyone. God bless everybody. Thank you so much.
Great job, John. Great job.